Welcome to the deep dive. You're here to cut through the noise, right? To get straight to the crucial information without getting bogged down. That's exactly what we're about.
And today, that focused exploration is tailored specifically for you and your MSRA revision. We're tackling Colles fracture. We'll be using the notes you've provided. Our aim is really to distill this topic into something, clear, memorable, and high yield for your exam.
Think of this as your express lane to understanding Colles fracture. We'll cover everything from what it actually is, how it happens, who's most at risk, right through to how it's managed and what the potential outcomes look like. So yeah, let's just dive straight in.
Okay, let's start with the definition. So a Colles fracture, it's a break, specifically in the distal end of the radius bone. That's the larger of the two forearm bones, on the thumb side.
Got it, the radius, near the wrist. And what's the absolute key feature?
The defining characteristic is the dorsal displacement of the broken fragments. So the broken end moves backwards towards the back of your hand. You could maybe think D for dorsal displacement.
Dorsal displacement. Okay, so
Yeah.
it's a specific type of distal radius fracture.
Exactly. And it happens right near the wrist joint. There's a really classic visual sign associated with it, too.
Ah, yes, the one that looks like cutlery.
That's the one. The dinner fork deformity. If you imagine a fork lying face down, the shape kind of mimics how the wrist can look with this fracture. It's quite a memorable image, although sometimes the term gets used a bit more broadly for, any distal radius fracture with that backward displacement.
Okay, dinner fork deformity, easy visual cue.
Yeah.
So how does this actually happen? What's the typical story, the etiology?
The most common way, it's usually a fall onto an outstretched hand, the classic FOOSH injury.
Right, you instinctively put your hand out to stop yourself.
Precisely. But doing that sends a pretty big force up your forearm right into the wrist joint.
Ah, so the impact just shoots straight up the arm.
Yeah, essentially. The mechanism involves what we call axial compression force straight up the bone, but also some bending and rotational forces too, all acting on the forearm and wrist.
Okay, that makes sense. The force hits the wrist at an angle, causing the break. So who tends to get these fractures most often? What are the risk factors we need to keep in mind?
Well, older age is definitely a big one. As people get older, bone density tends to decrease, making bones, more brittle. And closely linked to that is osteoporosis. It's a major underlying condition that significantly ups the risk. Think O for older and osteoporosis.
Right, weaker bones are much more likely to break under that kind of impact.
Yeah.
What else?
Having a history of previous fractures can be a factor, or maybe some existing bone deformities. Certain medical conditions, too, like rheumatoid arthritis, can affect bone health.
Okay.
And then there are lifestyle things like jobs or activities with repetitive wrist movements, or just a generally higher risk of falls.
And there was an interesting point in the notes about men.
Ah, yes. That men who get a Colles fracture seem to have a higher risk of getting a hip fracture later on, even more so than women with a Colles fracture. It's a point worth noting about overall bone health.
Definitely something to consider. Okay, so let's get into the pathophysiology. What's actually happening inside the bone?
Sure. So at its heart, it's a disruption of the bone's structure, its integrity, right at the end of the radius.
Okay.
The fracture itself is usually transverse, sort of straight across, or maybe oblique at an angle. And the location is key.
Where exactly?
Typically about 2 to 3 centimeters, roughly an inch proximal to the wrist joint. That 1-inch marker is pretty classic.
Right, about an inch away from the joint itself.
Exactly. And like we said, the distal fragment, the bit further down your arm, gets pushed backwards dorsally. And that displacement is what causes the visible deformity.
The dinner fork shape.
Okay.
Dorsal displacement, about an inch proximal.
Got it.
Yeah.
Now, if someone comes in and you suspect a Colles, what else could it be? What are the differentials?
Good question. You always have to consider other wrist and forearm injuries. A Smith's fracture is a big one.
How's that different? It's basically the opposite of a Colles. The distal fragment is displaced volarly towards the palm side. So think S for Smith goes the same way as the palm.
Ah, okay.
Yeah.
Opposite displacement. What else?
You could have a scaphoid fracture. That's one of the small carpal bones in the wrist. It can also happen from a FOOSH, though the pain might be more localized in the snuff box area. And don't forget the ulnar styloid, that bony bump on the little finger side. It can fracture along with the radius or sometimes on its own.
Right, so you need to check for associated injuries too. Okay, how common are these Colles fractures? What's the epidemiology look like?
Oh, they're very common, especially in older adults. It's actually one of the most frequent fractures you'll see in that age group.
Really?
Yeah, the incidence really climbs with age, and there's a noticeable peak in postmenopausal women, largely because of the higher rates of osteoporosis. That's another key group to remember.
So definitely something you'll encounter often, particularly with older patients. How do they usually present? What are the clinical features we should be looking for?
Usually it's pretty obvious. The patient will complain of quite severe pain, will be swelling, and definite tenderness right over the wrist area. And of course, that dinner fork deformity we keep mentioning, often you can just see it.
The visual cue sounds hard to
It
miss.
often is, yeah. They'll also have trouble moving their wrist, obviously, maybe some bruising, and just difficulty using their hand for anything.
And the history.
Typically, they'll tell you they fell onto their outstretched hand, that FOOSH mechanism again.
Okay. And on examination, besides the deformity?
Well, you confirm the deformity, the swelling, the tenderness over the distal radius, but it's really important to also feel along the ulnar styloid and even up near the elbow, the radial head, just to check for tenderness there to rule out associated fractures.
Good point. Anything else crucial on exam?
Absolutely. You must check their neurovascular status. Specifically, assess the median nerve. Ask about numbness or tingling in the thumb, index, middle finger. Signs of potential compression, like acute carpal tunnel.
Right, nerve damage is a definite risk. So, quick recap from memory. Older person, often osteoporotic, falls on their hand, gets wrist pain, swelling, and that classic dinner fork look. Check the nerves.
You've got it. That's the core picture.
So how do we confirm the diagnosis? What investigations do we need?
X-rays. Plain X-rays of the wrist are the standard first step.
Which views?
You need at least two. An AP, antero-posterior, so front to back view, and a lateral, which is the side view. These usually give you a clear picture of the fracture site. You can see how much it's displaced or angled, and spot any other breaks, like that ulnar styloid we mentioned.
Makes sense. Are there times when you'd need something more than an X-ray, like a CT or MRI?
Yes, sometimes. If it looks like a really complex fracture, maybe shattered into multiple pieces, or if it goes right into the joint surface, what we call intra-articular, or if you suspect there might be significant ligament damage that you can't really assess well on the X-ray, then yeah, a CT or occasionally an MRI might be helpful for more detail.
Okay, diagnosis confirmed. Let's talk management. How do we treat a Colles fracture?
Well, it really depends. There isn't a one-size-fits-all approach. You need to look at the fracture itself. How stable is it? How much is it displaced? And also the patient. You know, their age, their activity level, their overall health.
So it's tailored. What are the main options?
Broadly, it's either conservative or surgical.
Okay, tell me about conservative first.
So if the fracture is minimally displaced, or if we can manipulate it back into a good position that's called reduction, and it seems stable, we can often treat it conservatively. This usually means immobilizing the wrist in a cast or sometimes a splint. The goal is to hold the bones in place while they heal. Pain control is obviously important too.
And regular checks.
Oh, yes. Follow-up appointments are crucial, usually with repeat x-rays, just to make sure the bone fragments haven't shifted in the cast.
Right, and when would you lean towards surgery?
Surgery comes into play mainly for fractures that are significantly displaced and can't be properly aligned with manipulation, or if they're inherently unstable and likely to slip again, even in a cast. Also, open fractures where the bone pokes through the skin always need surgery. And importantly, if the fracture goes into the joint surface and disrupts the smooth cartilage lining, that articular incongruity, surgery is often needed to fix that properly.
To restore the joint surface.
Exactly. To try and minimize the risk of arthritis later on, surgery might involve plates, screws, sometimes external pins to hold everything together.
How long does healing usually take?
The bone itself typically takes about 6 weeks to knit together reasonably well, but that's just the start, really.
What do you mean?
Well, full recovery, getting back strength, full range of motion, using the hand normally, that takes longer. And it almost always requires dedicated rehabilitation.
Physiotherapy.
Absolutely essential. Physio helps tackle the stiffness that inevitably develops, improves the movement, builds the strength back up. It's key for getting good functional use of the hand and wrist again.
Right. And there was that interesting point about older patients and surgery versus casting.
Yes, that's worth remembering. For patients over, say, 60, studies often show that even if the x-rays look a bit better after surgery in terms of perfect alignment, the actual functional outcome, how well they can use their hand day to day, is often pretty similar to those treated just with a cast.
So even if the alignment isn't perfect on X-ray with casting, their function might still be just as good.
In many older, less active patients, yes. It's an important discussion to have when weighing up the risks and benefits of surgery versus casting in that age group.
Very important practical point. Okay, so overall, what's the outlook? What's the prognosis typically like?
Generally, it's good. With the right treatment and rehab, most people do regain good function in their wrist and hand. Like we said, healing takes weeks, rehab takes months, but the end result is usually satisfactory.
Are there things that affect how well someone recovers?
Definitely. Factors like the initial severity of the fracture, whether there were other injuries involved, the patient's age, their general health, and crucially, how well they stick to the physiotherapy program. Compliance with rehab makes a big difference.
Yeah, you have to put the work in. Now, even with good treatment, things can sometimes go wrong. What are the potential complications?
Unfortunately, yes, complications can happen.
Yep.
One is malunion.
Meaning?
That's where the fracture heals, but in the wrong position, maybe still angled or displaced. This can lead to ongoing pain, stiffness, or a visible deformity.
Okay, what else?
Less common, but more serious, is non-union, where the bone just fails to heal together at all. Stiffness, as we mentioned, is pretty common in the wrists and fingers after being immobilized.
Right.
Then there's the risk of nerve damage, especially that median nerve, leading to carpal tunnel syndrome symptoms, either acutely from swelling or later on. Blood vessel injury is rare but possible.
Any others?
Well, acute compartment syndrome is a surgical emergency, severe swelling inside the forearm, cutting off blood supply. It doesn't happen often with wrist fractures alone, but you need to be aware. And then long-term, persistent deformity can limit function. There's a higher risk of developing arthritis in the wrist joint down the line. And finally, there's a condition called complex regional pain syndrome, CRPS. It's a difficult chronic pain condition, thankfully not super common, but it can occur after injuries like this. It involves persistent pain, swelling, skin changes.
Wow, okay, quite a list. Maybe a quick way to remember some. You mentioned MNSC.
Yeah, you could think M for malunion, N for non-union and nerve issues, S for stiffness, C for carpal tunnel or compartment syndrome, maybe A for arthritis risk, and CRPS. It helps to have some hooks.
Definitely helpful. Okay, that feels like a really thorough run-through of Colles fracture. Just to quickly summarize the absolute key takeaways for you listening, it's that common distal radius break, dorsal displacement, think dinner fork, usually from a FOOSH, especially in older osteoporotic individuals. Diagnosis is via X-ray, treatment is casting or sometimes surgery, but rehab is vital. Prognosis is generally good, but be aware of those potential complications like malunion, stiffness, nerve issues, and CRPS.
Nicely summarized. And we really hope this deep dive has helped solidify your understanding for the MSRA.
We do too. And feel free to rewind, listen again, whatever helps make it stick as you revise.
And just a final reminder, for more excellent MSRA revision resources, do check out pastmsra.com.
And framesra.com as well, both great sites.
Definitely.
Right, that brings this deep dive to a close. Thanks so much for joining us.